I'm Dr. Gaurav Agarwal from Palestine Regional Medical Center in Palestine, Texas, and we'd like to talk to you today about using IVUS in peripheral vascular procedures. The argument to use IVUS is very simple. Despite its long history and reliability of angiography, it has several limitations. We usually use two-dimensional projection image of a lumen, and the wall thickness cannot be measured and the plaque cannot be adequately visualized. This results in an underestimation of the amount of plaque by angiography, which also leads to an underestimation of stenosis. The assessment of atherosclerosis can be improved by an imaging modality that has an inherent larger magnification than angiography and that actually directly visualizes the plaque. Intravascular ultrasound, or IVUS, fulfills this criteria. Intravascular ultrasound demonstrates a representation of the lumen and plaque in vitro compared to histology. There is a very close intra-observer and inter-observer variability of measurements made from intravascular ultrasound. This is in stark contrast to traditional angiography. Phantom studies of stenoses in tube models demonstrate that angiography clearly misrepresents the severity of stenosis. This is worsened when the lumen contour is irregular and calcified. Whereas intravascular ultrasound reproduces a cross-sectional image that actually accurately determines the artery lumen within itself. In vitro studies of balloon angioplasty also demonstrate that intravascular ultrasound accurately represents the changes in structure of the artery segments following balloon dilatation. Therefore, vessels with dissection flaps, IVUS is a key measurement tool. Also, lesions with high fibrosis, calcification, and lipid composition can be easily identified using IVUS. A study by Washington Hospital Center looked at IVUS imaging and no IVUS imaging and implantation of drug-eluting stents, period. The study showed a 65% lower stent thrombosis rate and a 29% lower TLR in patients who had IVUS used at the time of stent deployment. The study really concluded that IVUS using drug-eluting stent implantation has a potential to influence treatment and strategy and help our patients do better. This is a pictorial graph showing the same data, and again, clearly IVUS use decreased TLR and stent thrombosis in this study. Now this is for coronaries, but if something was true for the coronaries, the likelihood is it's actually probably true for peripherals as well to some extent. Another study by Constantini also shows the same data. Pretty similar numbers on both those graphs that we mentioned. So what is the indication for use for IVUS? I think to determine whether the lesion is significant or not, whether once the stent is deployed, whether it's appropriately deployed, whether the stent is opposing the vessels and it's adequately placed, to decide what stent diameter I need to use, to decide what stent length I need to use. With the new IVUS catheters with markers on it, it's pretty easy to determine the length of the lesion. The amount of plaque burden and the plaque tissue type, and to calculate a percent stenosis are pretty clear uses of IVUS as well. From 2004 to 2008, in a study published in the Journal of Vascular Surgery, 93 patients underwent angiography for lower extremities. This was an observational analysis. At the time of angiography, lower extremities were interrogated using IVUS pullback. Angiography and IVUS interpretation were similar for luminal diameters, but the external vessel diameter by IVUS was significantly greater. I personally believe that adequate vessel sizing is key to reducing problems in the lower extremities. I tend to stent my vessel using the external vessel diameter measurement rather than the luminal vessel size. At least in my experience, reduces stent fracture rate and reduces restenosis of these stents. The other interesting data that came out of the study was that IVUS clearly was a better assessment of calcification. By angiography, about 40% of these lesions were called moderate to severely calcified. But by IVUS, only 7% of these lesions were noted to be severely or moderately calcified. This makes a big difference in the periphery, and it also determines what modality is used in order to treat our patients. By looking at calcification on angiography, we could be using other modalities like atherectomy devices to treat the lower extremities. However, they may not be needed in certain cases based on IVUS data. So in at least my experience, I tend to use IVUS every time before I decide to use an atherectomy device to identify the plaque and the type of plaque and the structure of the plaque, and then based on that decide what modality would best suit the procedure. In this peripheral study, clearly ISR occurred in 38 patients, or 5.7% patients, which is a little lower than normal, and 21 stent fractures were identified in these follow-up groups. The restenosis rate in the patients with stent fracture was clearly higher than non-fracture group. I think the data is pretty clear on this. The more the fracture, the higher the restenosis rate in a stent. Multiple different studies have looked at this, and essentially the data that sticks out of this is that the longer the stented segment, the higher the restenosis rate, and the more the fracture rate of a stent, the higher the restenosis rate. Both are bad prognostic indicators for our patients, and both are a problem right now. So why do I use IVUS? I use IVUS for answering a few questions in the cath lab. The most important question is, am I sizing the vessel correctly? Is there a stenosis that needs to be fixed? Sometimes I just don't know where I am, and IVUS tells me exactly where I am. Sometimes the patient's symptoms and how the vessel looks, there's clearly a difference, and I need to know whether the stent I just planted looks good, or is there a dissection flap, distally or proximally to the stent. So IVUS is used for all of those in my lab. Let me just show you a couple of cases that we did, which I think would support my argument. Here's a patient with selective angiography of the right common iliac artery. As you can see, the ostia of the external iliac artery seems to be moderately stenosed. Since we had a wire down this vessel, we actually IVUSed this lesion. Now, looking at it by angiography, I think most people would argue that this vessel is moderately, at least mild to moderately stenotic, and really does not need to be intervened on. IVUS tells a different story. The distal vessel actually ends up being about an 8.5 millimeter vessel, which, looking at it, it didn't look that big. So if I had to stent it, I would measure the external luminal diameter. I'd end up putting probably a 10-0 stent. If I just went by angiography, I probably would have put in an 8-0 stent, assuming the vessel was about 6.5 to 7 millimeters. Here's the lesion on IVUS imaging. Clearly the image shows that the plaque is rather eccentric and the lumen is really stenosed. This was in the early stages of me using IVUS. I didn't believe my data, and so I went and actually obtained a pressure gradient across this lesion, which clearly showed a pressure gradient of about 40 millimeters of mercury, consistent with obstructive lesion. Therefore, this patient's right lower extremity pain was from this lesion. This lesion was stented, and the patient did extremely well. This is a case of sometimes IVUS is just used to figure out where you are. This is a CT scout image and a followed up CT image clearly showing a missing right renal artery. We could not engage the vessel because we suspected a spontaneous dissection of the right renal artery. At this time, using a no-touch technique, a 014 wire was advanced into the renal artery. Before doing any manipulation of the vessel, I clearly had to be sure whether I'm in the true lumen or the false lumen. Obviously, balloon angioplasty of the false lumen would be pretty detrimental in this case. The patient had about 1/3 of the inferior pole of the kidney still viable, and I wanted to save that given the patient's symptoms of severe abdominal pain. This IVUS image clearly shows that we're intraluminal. It also shows the flap and the thrombotic material and the spontaneous dissection. The next image shows our final result. which we were really successful in fixing this renal artery, and the patient's pain instantly went away after the stent was deployed, and she did really well. The next case I'd like to share is to look at these vessels and see if we're actually truly measuring them correctly. Here's a case where the vessel seemed to be, I'll show you the angiogram. This vessel clearly is in the anterior tibial artery. The lesion is actually right at the distal popliteal artery above the trifurcation. And it's hard to kind of decide how big this vessel is, what kind of balloon or stent we need in this vessel. IVUS shows a heavily calcified lesion and a vessel that's at least 4.5 millimeters in size. We actually took a 2.5 millimeter balloon and angioplasty this lesion, thinking that it was actually about a 2.5 to about 3.0 vessel. And clearly when we IVUS this lesion, we were surprised. Here's another example. This lesion obviously needs to be fixed. It's really tight. IVUS of the distal vessel shows that this vessel is also about 5 millimeters, and this is a vessel below the knee. Clearly, again, without IVUS, we would have probably angioplastied this lesion with a 2.5 or 3 millimeter balloon and left it alone. However, with IVUS, we were able to use a 4.0 balloon and angioplasty this lesion with an excellent result. Here's an external iliac artery. On the right common iliac artery, there's a pretty nasty stenosis which extends into this mid segment of the common iliac artery as well. And we weren't sure how big a stent we need to put in here. And IVUS was again used to determine that. Distal to the lesion, the vessel size was 10.5. And proximal to the lesion, the vessel size was 11.1. We ended up using a 12.0 stent in this vessel, a self-expanding stent, and the patient did well. I worry if I had just gone by angiography and probably put in a 10.0 stent, I would have undersized that stent and probably increased my restenosis rate, as well as the likelihood of stent embolization or more complications. So, in conclusion, my theory is that really further studies are needed to look for adequate imaging modalities and imaging technology, but stent restenosis rate in the lower extremity may be because we're not sizing the vessel right. I think at least in my laboratory, we ended up having to change the entire stent inventory that we had once we started using IVUS for the lower extremity. We were deploying a lot of 6.0 and 7.0 stents before we did IVUS, and our inventory essentially changed to 8 and 10s once we started using IVUS. We also really haven't noticed much stent fracture in our cohort of patients, which I think is secondary to sizing the vessel again appropriately with IVUS using external vessel diameter instead of just the luminal diameter. I challenge everybody to use IVUS in the periphery, and I'm pretty sure that everybody would be really surprised that we're completely missizing these vessels. Thank you for your time.